You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Welcome back to the Pediatric Pharmacist Review. I am one of your hosts, Justin Cole from Cedarville University and the Center for Pharmacy Innovation here. Today, Jenna is not able to join us as a co-host, so we've got Mary back this week. So, Mary, thanks for joining me to host this episode.
Thanks for having me, Justin.
Oh, yeah, this is getting to be a regular occurrence, so I'm looking forward to continuing to have you here on the podcast. Our guest today is Dr. Amanda Weber. She is a pediatric epileptologist at Nationwide Children's Hospital in Columbus, Ohio. And I don't know how much this will come up over time, but wow, a decade and a half ago, Amanda, we actually got to work together, which was a blast. So we're excited to have you on the podcast today. What we're trying to do is simply understand a physician's perspective on having pediatric pharmacists on your clinical team as collaborators. So we really are excited to hear from you and your experiences and learn a bit from you. So thanks for joining us, Amanda.
Thanks so much for inviting me. I'm excited to be here.
Yeah. All right. Well, I want to turn it over to you and just maybe allow you to tell us a bit more about your own training and your own background and some of the things you get to do there at Nationwide Children's.
Okay, so I did all of my training at Nationwide Children's Hospital, starting from residency, and we had a clinical pharmacist kind of integrated into multiple teams from the very beginning. So we had ones that I specifically remember were clinical pharmacists who participated in rounds in the infectious disease ward, in the ICUs. And then, of course, once I moved on to neurology residency and fellowship, we had very active participation with our clinical pharmacists in our complex epilepsy clinics and just really available to us kind of along the way as we were learning different medications, medication interactions, and also to help troubleshoot patient concerns if there were specific issues with patients taking certain medications and things like that. So all along through training, we have had a pretty strong source of support from clinical pharmacy, which I've really appreciated.
I feel like we went hand in hand with that. Like, I really appreciated having like the MD so close to me as a resident, because I started off like also as a pediatric pharmacy resident, and then I kind of became friends with the pediatric medical residents, and from there we like grew together. They became attendings, I became the pharmacist on the unit, and then it just became such a nice environment. And I totally remember that. So
Absolutely.
You had a pediatric pharmacist on your care team in residency. In what capacity did they practice? Did they attend rounds, answer questions? Was there a collaborative practice agreement?
Yes, so they attended rounds, especially in the ICU, and then they were also kind of available behind the scenes to help get medications covered and prior authorizations done, and to help double check dosing, and all those sorts of things.
Now, Amanda, I know that you practice in complex epilepsy as well. So I would love to hear a little bit more about that particular clinic and the interprofessional nature of how you approach treating kids and working with families when they have often genetic epilepsies or very complex epilepsy disorders.
Yeah, that's a great question. So our complex epilepsy clinic is really multidisciplinary. It has the epileptologists, it has neuropsychologists, there are genetic counselors, psychologists, neuropsychologists, clinical pharmacy. And so everybody comes together on the day of this clinic to help address each patient in a really multidisciplinary way, and to assess kind of what their struggles and needs are. And so you're right, there are a lot of patients with complex genetic conditions who require pretty specialized medications, and have really a lot of healthcare needs and pretty complex needs across many different specialties. And so it's really helpful to have pharmacy there for a couple of reasons. A lot of times these patients are on multiple different medications from multiple different subspecialties. And so just having the pharmacist's very involved in looking at medication interactions and how we should modify dosing related to other medications that they're on, how best to administer medications. Maybe if the patient has a G tube or a GJ tube that's, clogging with certain medications or certain things like that, they can really help troubleshoot those circumstances. And also, it's very helpful to have them there to help minimize errors as well, like in terms of medication dosing and things like that. So with that team, we also kind of work together on different research initiatives. And so we have worked together within our department on multiple quality improvement projects and things like that together with clinical pharmacy to really improve patient care. And so some examples were things like we looked at compliance with abortive medications. So in children with epilepsy who are having frequent prolonged seizures, we always provide them with a seizure action plan that helps detail for the parents when to use a rescue medication and how much to give and things like that. And several years ago, we looked at our baseline data and saw that across the board, the abortive medications were not being properly prescribed in various places like the emergency room, by primary care, by even within neurology, because all of the medications are weight-based and things like that. As patients grew, sometimes those weren't being adequately adjusted. And so we worked with clinical pharmacy and multiple other of the clinicians to improve compliance so that doses were being double checked, so that within our ordering system we could have the dosing parameters and guidelines there, and kind of hospital-wide education initiatives to help improve that. So that was a great project and very successful, and really helped to helped patients get better care overall. And so having clinical pharmacy involved has really been helpful from that perspective.
Amanda, I think back to my own experience there as part of that team, and even getting to work on some of those things alongside of you and others. It's amazing how when you bring different perspectives to the table, new ideas happen that further patient care. And it's not just about saving money, but it's about really helping the patients have the highest quality care. And we've talked on our podcast even just recently about this idea of the quadruple aim that we're aiming for. And one of the key ways to do that is just through interprofessional collaboration. And just to tell one brief story too, I'm actually very grateful to Amanda herself, because one of the very first studies that I got to be a part of publishing was looking at the use of topiramate for the treatment of infantile spasms. And for me, I understood the drug really well, and I had a pretty good understanding of the condition. But by golly, I can't read an EEG. And so I learned so much by collaborating with Dr. Weber and another collaborator as well to learn, number one, how to even approach retrospective clinical research. And then secondly, to simply further my understanding of how much it takes a real interprofessional team to take great care of kids. So I'm grateful to you, Amanda, for allowing me to be a part of that project. And I think it's just another example of how we all in our different fields need to be collaborating to advance the care of the kids that are coming across our paths, and to just, again, care well for everyone that's there. So thanks for all those examples. I think those are a lot of fun, even for me to reminisce about a little bit.
Yeah,
Absolutely.
really. It's funny, we're also pyramid buddies because one of my first projects collaborating with my neurologist, shout out to Dr. Michelle, was a project on topiramate, and it was looking at topiramate rectal suspensions and how we had to transition patients over to rectal if they were like NPO and we had no other options in the PICU for topiramate. But it was like a lot of learning, and that brings me back so many memories of neurology rounds every afternoon at 2, where we would look at the EEGs. I'd be totally clueless, but they would see the hips arrhythmia, and then it would like trigger my brain to think of like, okay, do we work on coordinating ACTH? Do we do like the high dose prednisolone protocol, or are we doing Sabril? Like, is it tuberous sclerosis? Is it idiopathic? And then all of the ideas shoot around, and like neurology rounds honestly were my favorite because it was just a collaboration of the minds.
Yeah, that's a great example.
Amanda, I would love to know, if you think back on your training, were there any interactions you had with pharmacists that maybe changed the way you practiced? Maybe it was how you used a certain drug or monitored it differently, or maybe selected patients that should or should not receive one. Are there any stories or specifics that come to mind when you think about having a pharmacist work with you, how it's formed your own practice?
Absolutely. So there are a couple of things I can think of. One is I worked on a project that was aiming to improve knowledge in adolescent girls about kind of the interactions between anti-seizure medications and oral contraceptives, and also just the importance of prescribing folic acid, mostly because of all of the potential teratogenic effects of the anti-seizure medications. And so one of my QI projects focused on kind of improving access to folic acid for these patients. And with that, I learned so much from the pharmacist who was involved, and both about anti-seizure medication interactions with oral contraceptives, which are very, very confusing. And there are so many different ones, and depending which medication and which dose you're on, it can be a lot to keep track of. And then also just the practicality or just the practical aspects of prescribing folic acid and having patients be adherent with that. And during those projects, I had access to different pharmacy staff to help also directly explain that to patients, which I thought was really impactful. Sometimes just hearing it from somebody else can be really helpful to the patients. So
yeah, I think also just like having a pharmacist as backup. A lot of times, like the neurologist would try to explain something to the parents, and the parents are like, no, like I don't believe that. And then they'll be like, oh, but I have the drug expert, and the drug expert will come in. And then just like having that, like that person to tag team with, and like on the same token, if I'm explaining something to a parent and having like a physician like, oh no, I have someone to like tag team in and also like help me explain. I feel like that helps a lot too. So like things like birth control are super confusing. Like I can't even tell you all the different doses and products. I really always have to look them up, but just like having that backup and having that support is always nice.
Absolutely. And there are so many parents who are hesitant to add another medication or to even start medication in the first place, even for epilepsy that we have great success in treating, like childhood absence epilepsy. And so sometimes, I can talk to them at great length about these medications and how well they're tolerated and things like that. But just having somebody else, like you said, to be able to come in and that is their area of expertise, those specific medications, that can really give a different perspective to the families and really kind of help get the patient the best treatment.
Yeah, because at the end of the day, we're a team, and that's the most beautiful part about like medicine and where it's going. We're all a team. We all have our specialties. We all have our strengths and our weaknesses, and we kind of work on and off of each other to just provide the best care.
Absolutely.
So, Amanda, I know you practiced other places during your career so far as well. So have you always had a pharmacist available that maybe specializes in your area of pediatric neurology, or have you seen that practice varies from health system to health system?
It really varies. So the last place I was there for almost 8 years, 7.5 years, and we did not have access really to clinical pharmacists except in the ICU. And so there were so many additional barriers, unfortunately, to care, and really not a single source or a single person that I could rely on to help me troubleshoot or to ask these questions from. And so some of the things that I remember being especially problematic were getting approval for things like the medications for Lennox-Gastaut, or for in patients who had failed multiple other medications and things like that. Just getting access to some of the newer medications was really, really tough. Or for the patients with infantile spasms who needed, to be connected with ACTH or the REMS program for vigabatrin. The nurses were having to do so much behind the scene work to try to get those things done, that there were really delays in care as a result of that. And so that was one place that I really, really missed having a clinical pharmacist within our team, was especially managing those patients.
And Amanda, just thinking back in the different areas where you've had a pharmacist, in what areas do you think pediatric pharmacists are underutilized?
So I think that I wish that they were honestly available in every single one of our clinics, which I know is hard. But we really, they just make such a positive impact when they're there. And it's so helpful to be able to rely on a clinical pharmacist to help with patient teaching and with discussions with families about side effects, that I really wish that they could somehow be integrated to all of our general neurology clinics as well, and also to our general neurology rounds, just to be present during rounds like they are in the ICU. I also think we're very lucky here at Nationwide Children's Hospital, because the pharmacists really play a role in things like prior authorizations and helping to appeal when medications are declined by the insurance companies, and even just getting rapid access to medications that are expensive or need certain approvals. The pharmacists really help with those things. And so I wish that there were more of them so that we could, kind of expand some of those services.
Amanda, it's interesting. I think back over the last 20 years of my career, and when I started working with the neurology team there, I knew of probably 5 pediatric neurology pharmacists. There were almost none of us nationwide. And now when you think about where pharmacy practice has gone, really neurology has become one of those areas that rapidly expanded in the last 10 to 15 years, namely because of all of these medications that you've mentioned that have a lot of drug interactions. They may require therapeutic drug monitoring where we're checking levels or other things, or they have REMS programs, as you've mentioned. It's amazing how much expansion there's been in the armamentarium we have to treat epilepsy and other neurologic conditions, but it's meant some specialty drugs that require a lot more effort and a lot more oversight. So it's fun to me to hear that, yes, there is a lot of opportunity for growth, but it's also exciting to think through that there has been that growth. And I think that trajectory hopefully will continue moving forward. Well, we also wanted to ask, are there any just cool lessons that you feel like you learned from a pediatric clinical pharmacist, whether it was in your training or maybe another part of your career?
Yeah, so some of the most important things I think that I've learned, I work sometimes in the ketogenic diet clinic. And so learning about the carbohydrate concentrations in drugs, that stuff can be really hard to track down. But I have learned so much from our clinical pharmacists about different medications in the context of ketogenic diet. And so that's one. The other thing that I distinctly remember is there were different taste testing. And Justin, I can't remember if you did this. I think you did, but just having the ability, I remember on the ID floor tasting different antibiotics that were, just so that we could see what the patients were experiencing and why they were spitting it out and things like that. And I believe you did that with anti-seizure medications too, but I, for whatever reason, missed it that time. But that's one of the funniest or coolest things that I guess I remember being taught by you guys. Yeah.
When I did that for my residents, I actually made it like a wine tasting. So I had like a scoring sheet and we played classical music and I just had it all set up with like cheese and crackers and they got such a kick out of it. But some of them didn't realize that we had a little bit of flagyl. So then later that night, like they had a glass of wine or something. And the next day they were like, okay, lesson learned, never, ever, ever mixing metronidazole with alcohol ever again.
Oh, Mary, you're way more creative than I am on that. Oh, that's an unforgettable experience right there. That's great.
And then Amanda, in your perfect world, where would you integrate a pediatric clinical pharmacist to your care team? I feel like my wish list for this is like one of the hospitals here, each physician has their own personal pharmacist. And it's a cancer institute. So I totally get that. But that would be like ideal for me to just be like a physician's buddy that just like you work hand in hand together in a clinic together on the floor, like how most physicians have like a nurse practitioner. But what's your ideal like pediatric pharmacist arrangement?
Oh, that would be amazing. If we could have that, that would be absolutely amazing. But, another thing that I think would be really helpful would be to have a clinical pharmacist kind of generally assigned to specific patients or have patients just like they have, just like a patient would have a primary neurologist. If they had a primary clinical pharmacist that they could directly ask questions and send my chart messages to and things like that. I think that would be really helpful. And that way the pharmacist could know the family could have a direct contact point. And we could also then as providers or as physicians, we would also know who to specifically direct questions to about those patients. And I guess it doesn't make sense practically for every single patient probably to have a clinical pharmacist, but maybe specific populations of patients like all of the Lennox-Gastaut patients kind of are generally overseen by a couple of pharmacists or something like that. I think that would be really ideal, but again, ideal world.
That's kind of our goal right now at Perfecting Peds, because we are attributed through like the health plan and we do have our set patients. It's nice. It's nice building the relationship. So whenever we do see these parents, it's like seeing an old friend, like, oh, hey, you got a haircut, or like, how was your vacation? And then you have that pharmacist that like knows that child really well. So it's coming hopefully for the whole nation. We're in Minnesota and Pennsylvania for now.
Oh, that's great to hear.
Yeah, and I'll just second that idea. When you think about, especially in your practice, Amanda, of peds neurology, most kids with medical complexity are going to have some type of either neurologic or sometimes behavioral comorbidity, but neurology comorbidities are just so prevalent in that population. And so to me, that seems like a very natural place for pharmacists to be more involved, whether it's just, like you said, being available, right? Maybe a pharmacist doesn't need to see all of these patients, but can they be available for those who really have questions and where it would be helpful?
Absolutely.
Amanda, one other thing that I know that a lot of pharmacists will be involved in is the development of clinical pathways or different protocols that an institution might follow. And again, that's a collaborative effort, right? That's not just a pharmacist effort. But tell me, is that something that you have seen in your practice?
Absolutely. So one of the most recent projects I've been involved with is the treatment of status epilepticus within our hospital. And so around that, we have had multidisciplinary teams working on decreasing the length of time to abortive medication administration within the hospital. So when there's a seizure that occurs within the hospital, how can we most quickly get the patients their first line benzodiazepine medication. And so Dr. Ostendorf from Nationwide Children's Hospital kind of headed up a quality improvement project that required a lot of support from pharmacy. And that kind of gathered some baseline data that on average it was taking about 14 minutes to get patients their first line medication from the time of the onset of seizure. And so they really changed the way that that practice happens at our hospital, in that previously there was intramuscular or IV medication that was given. And now just about across the entire hospital, all of the nurses have been trained to use intranasal midazolam first line. And through various teaching initiatives, it required all kinds of rehaul in terms of the way that providers are entering orders, how order sets look, where medication is stored, the training initiatives, all of those things had to come together, but it's resulted in a pretty dramatic improvement in care. And so now the average time to first medication is about 7.5 minutes. So almost cut in half. So that was a place that I know that pharmacy was very involved and very helpful. And kind of along the same thought process, our status protocol in general is being revamped, and we've really utilized our clinical pharmacists to help us decide which medications to use first line after benzodiazepines fail. So we are in the process of rolling out to most of the floors now utilizing levetiracetam first line. But to be able to do that, we've had to change what is in the Pyxis and, notify everybody, change all of the order sets. And so pharmacy has been very, very involved in that whole process. And ultimately, it's resulting in better patient care, obviously, which is the most important thing.
Yeah, I remembered working on like the status protocols and like figuring out the pump settings and all that stuff. So it was fun working together and like having the ideas and working together on clinical pathways, because we think that a pathway is something so simple, but it takes so much teamwork. So it takes like the brainstorming between the multidisciplinary team of like physicians, pharmacists, nurses, but then it takes like the pharmacists to program everything and to figure out logistics, the nurses to educate on administration and process changes. So it really takes a whole village when it comes to things like clinical pathways.
That's true.
Well, Amanda, at the end of this episode, we wanted to maybe flip the tables a little bit and see, do you have any questions for us as a pediatric pharmacist, and maybe about our interactions with physicians and others on the healthcare team?
I would love to hear how interacting with us and how interacting with medical residents and the healthcare team has shaped and changed your practice.
Well, that's a great question. I could jump right on it, but Mary, do you have anything that you would say to start?
Well, I have like this bad trait of just becoming best friends with everybody and just wanting everyone to be my friend. So that was like one of the biggest sources of like friendships for me in the hospital was through the medical residents and the physicians. And a lot of them, we started off as friends during residency together, and we would grow on, and they would stay on as attendings. I would stay on as a pharmacist. And it was just nice, like working with your friends and just like rounding with your friends and just having that relationship where you trust each other. And it would be like, oh, whatever Mary says, like we can do that to the dose. And it was nice having that like really collaborative relationship with them. But then my other favorite thing was just learning. Like I learned that when you take an ammonia level, it has to be like put on ice, very specific. You can't shake it. Like you have to literally walk it straight to the lab. And that was like one of the most profound things I learned from the residents, but just like learning all the little medical tidbits and just like learning together, I think was one of the greatest things, because it just really opened the floor to being just a collaborative place where you're, like nobody is telling each other what to do, or like learning together and just like trying to progress with the care.
Yeah, I love those aspects. And for me, I think remembering being on rounds in the PICU when I was first training, I loved learning about the nuances of differential diagnosis and trying to figure out what's going on with a patient. And the reason why that was so helpful for me is, as a pharmacist, my job was to discern, are there any drug-related problems that may be at play here? But I, over time, learning from the residents and from the physicians I worked with, got even better at discerning, well, but there are other possibilities, and maybe there are other people that need to look at this beyond just my thought that it's a drug side effect. Especially, again, we're going back to anti-epileptics, but sedation in the ICU and all the various things that we give, there can be so many factors at play that may be impacting a patient's status beyond, of course, the drugs. And so I just loved that problem-solving process that residents showed me is so important. It's art and it's science. It's good listening to your patient and your families. It's also knowing the diagnostic tools that you have available to make the best assessments for your patient. And ultimately, we've got to do that well, and if we're going to know how to treat well. So for me, it just opened my eyes to how important that diagnostic process is, not only to getting to a cause for what's going on, but then guiding our treatment. For me, I nerded out on EEGs. I can't read an EEG still today. I don't have that training, right? But I loved going to the EEG room after rounds and looking for those spike and wave discharges and understanding what delta activity is versus something else. And I think Mary brought up the idea of hypsarrhythmia and seeing that in some of our infantile spasms patients. And so for me, even understanding the mapping of the different montages of an EEG was enlightening and just fun. It was fun to learn even just a tiny bit about it. So I think for me, the biggest thing was enjoying the learning, the relationships, but also appreciating the skill with which physicians and others are diagnosing patients and how that plays into their care.
I totally agree with you. I think learning all of the diagnostic implications really made me a better pharmacist because it made me more creative. It made me think like, okay, it's not just this, it could be so many other things. And I only know that because I listened in on rounds and I heard the differential and then I saw the symptoms and it all ties together. So it kind of just all like shoots into your brain. But then I tell my students, I'm like, one day you'll pull it out because you'll think of something, it'll connect, and then it'll somehow work out. I think another thing on a personal level that I loved with seeing and working with the medical residents is learning resiliency, because the training is so intense. Just the residency itself is intense. Some days on the floor are just intense, and just the fact that they're able to carry so many patients, still do a stellar job, and still keep their sanity was always great. Like I would always look at them like, okay, they're surviving, like I can survive. And I would always look to them as a beacon of hope. Like, okay, we'll make it through. Like it's a hard week, but they have it much harder. They can push through. We can all push through together.
I definitely felt that too, that as a team, we all lean on each other, even still day to day. Yeah.
Well, Amanda, it's been a pleasure, first of all, just to catch up. You're doing great, and I love hearing that you're doing great things still, being back at Nationwide Children's. We appreciate you coming on the podcast today. It's just been an absolute pleasure.
Thank you so much.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.